The rate on this ECG, 300, 150, 100, right at about 75, so that's normal. Rhythm appears to be sinus. We have upright P waves in lead 2. Axis, a little bit down in 1, up in F, up in 2, so maybe it's a little bit right axis shifted, but I think that this is close enough to isoelectric that I would probably not make that call. Intervals. So our PR interval stands out as being relatively short. We don't see much of a baseline here. We don't see much of a a PR gap there between before the QRS starts. The QRS also appears to be wide, right? So here it starts on a big box, or ends on a big box, and if we go back, it looks like it's probably about 120 milliseconds wide. But this is not a bundle branch block. You do have an R wave in V1. You do have a small V wave, S wave in V6. But take a look at what is actually causing the QRS to be prolonged. Here in the precordium, you can see that the back half of the QRS is nice and sharp and narrow. It's the front half that's widened. And so what you're seeing here is this is a delta wave where you have a gentle upslope to the QRS, and that is combined with a short PR interval. So this is consistent with a Wolff-Parkinson-White pattern. In addition to that, we do have some non-specific STT wave abnormalities. We've got some inversions here in V2, 3, and 4, maybe a little bit here in 3 as well. So those are the primary findings here. Sinus rhythm with a Wolff-Parkinson-White pattern. So why does a Wolff-Parkinson-White pattern exist? What happens is there is a pathway of tissue connecting the atria to the ventricles that is going other than the pathway through the AV node. So this pathway could exist just about anywhere between the A and the V. It could be lateral, could be anterior, could be inferior. You don't really know. And what happens is when the P wave gets to that pathway, it starts to conduct down that pathway and down the native AV conduction through the node as well. Those two depolarizations merge to create this QRS that's got this upstroke, this delta wave to it here. What does that mean for the patient? Well, those pathways, that accessory pathway, sometimes it only conducts in one direction. Sometimes it only goes A to V, sometimes it only goes V to A. Sometimes it's rate related, where it might go both ways, but if the heart rate is going particularly fast, that pathway becomes refractory and it doesn't conduct. So in the end, you may have a clinical syndrome with this, or you may not. If you just have the pattern and you have no symptoms, you have no palpitations, you've got no tachycardias, then you would just call it Wolff-Parkinson-White pattern. Once you have a clinical manifestation of it, you would call it Wolff-Parkinson-White syndrome. So this sort of thing becomes dangerous if, for example, this person was to go into atrial fibrillation, and let's say they didn't have any kind of rate restrictions on this pathway. Those atrial fibrillation impulses can travel down this pathway fast enough that they can overwhelm the ventricle and cause it to fibrillate. So that would be a dangerous thing if that was to happen. I mean, anytime somebody's got a repeating or a reentry phenomenon in the atria, it could generate a Wolff-Parkinson-White syndrome. The other thing that this could do is it can create an AV reentry tachycardia. So we're going to talk about AV nodal reentry tachycardia another time, but AV reentry means that you're going either up or down the AV node and then up or down another pathway somewhere else in the heart. So if you were to go down AV conduction and then back up this pathway, you could then set up a reentry where that reverse depolarization of the atria, that retrograde depolarization, then signals the next trip down the AV node, right? That's called an orthodromic tachycardia. So you go around, down the native, up the pathway. Or you could have it go the other direction, where it goes down the pathway and then backwards up the AV node. That would be called antidromic. But that is what an AV reentry tachycardia is. So yeah, those are the ways that it can manifest, and if you don't have any of those, then it's just an ECG pattern.